Howdy, y'all. This is Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of clinical practice. So if you're watching on YouTube, you notice I'm not by myself. I'm not at my house in Aledo outside of Fort Worth. I am joined by old school Lighthouse Project podcast co-host Mike Verkest.
What's up? Hello, good to see you guys.
And we're joined by Dr. Brent Myers.
Hey, good to see y'all.
So we got together here at NAEMSP in Austin. Gorgeous day outside. So, of course, we're inside talking to you about some research because those are just the kind of nerds we are. We wanted to do a paper really quickly because we all have places we want to go. We want to talk about a paper that is really cool. And there was some discussion on Twitter. And I think I saw in that discussion the point going at least 20, 30,000 feet over people's heads. So I wanted to talk about this paper to try to bring the point home. So the paper we're going to talk about is Intramuscular Adrenaline for Out-of-Hospital Cardiac Arrest is associated with faster drug delivery, a feasibility study. This was published in Resuscitation.
Get them binoculars on.
Yeah, get the reading glasses on. 2021. Is that right? I thought this was a much newer paper. Wow, this has been out a little bit longer. All right. This was published in 2021. It is by Dr. Pugh, Stoecklein, Tonna, Hoareau, Johnson, and Youngquist. And I'm pretty sure I mispronounced at least one of those. So this is a very interesting paper because if you remember the ALPS paper, this was the amiodarone lidocaine placebo in shockable rhythms. Yeah. It showed something I was not expecting at all. It said there's no difference.
And then they looked at it. Yeah, and they looked at it again.
Exactly. How did they look at it?
Well, they moved it out from IV to IO.
Yeah.
And then,
right.
Oh, maybe there is.
Maybe the rock smells something.
Yeah, maybe.
So the interesting thing so the secondary analysis, and I think we've discussed it here, is they just broke it out. Okay, what does amiodarone look like compared to lidocaine or placebo if you only give it via IV or if you only give it via IO?
And this was tibial IO, by the way, because there wasn't many humerals.
It's like 98% tibial.
Yeah, it was kind of before it was the thing.
And it was definitely before it was the thing. And I remember looking at the clinical question, does route of administration make a difference? Thinking, what the hell are they smoking? There's no way it makes a difference. And thank God I read beyond the title because it turns out it did make a difference. Yep. When you gave the drug via IO, there was no difference in survival. When you gave amiodarone via IV compared to placebo, improved neurologic survival. When you gave lidocaine versus placebo IV, there was improved survival to hospital. Holy crap. It works, but it only works if you give it IV. So when you see a paper that is proposing something that just seems outright stupid on its face, maybe they know more than you do, because the authors of that study certainly knew more than I did. So this study is looking at whether giving your initial dose of epinephrine in cardiac arrest via IV is better, and we'll talk about what better is, than giving it IV. And I'm like, wait, IM versus, I screwed that up, didn't I?
Twice, or IV.
Well, that would be probably a pretty solid bet on the null hypothesis.
Yeah, I mean, it would take a minute to run that.
I'm
guessing it would be a difference, yeah.
Then again, I would have thought, not wearing a parachute when you jump from a plane would have been bad.
Depends where the plane's at.
Right.
So IM Epi versus IV in cardiac arrest, I saw that and said, well, that's stupid. There ain't no blood flow in cardiac arrest. There's no way the Epi is going to get from here to where the heart. Well, it's a good thing we looked at the paper. So let me run through the PICO question. We'll go over the results. I think you have some questions about table 1, Dr. Myers, and then we can kind of talk. Actually, the other thing is they have here at NAEMSP, these authors have given us some additional data, so we'll go over that. And then we'll talk about why this might be useful. All right, so the methods of this trial, this was an observational study. It was IRB approved. It's a before and after methodology, which means they essentially did a protocol change. And they said, we want to study the results of the impact of that protocol change by comparing the before data to the after data. They were very clear this is a feasibility study. This is not the gospel. We're just trying to see if we can do this. And when you see feasibility study, that essentially means that you're setting up a randomized control trial. So they're very clear about that. The population they were looking at here was adult, non-traumatic, out-of-hospital cardiac arrest treated by the Salt Lake City Fire Department. The intervention, this is the after group. So their protocol is they would get there and give epinephrine 1 to 1,000, 5 milligrams IM as soon as possible in the arrest, and then everything else they did would be IV or IO. The comparison group, the before group,
just your standard 3 to
start
5
the
minutes,
line,
1 milligram.
exactly. Their outcomes here were times. The whole thought on this is the reason IM Epi might be useful is you can get it in faster. We know that from the Rampart trial, where they randomized control trial where they looked at IV versus IM anticonvulsants, and they found that you get the damn drug in faster when you don't have to start an IV first. This is one of these, well, no shit.
Right. Yeah.
But I'm glad you did the paper. So it worked for seizures. Did it work here? That's really what they were looking for. Now, their primary outcome, when we talked about times, it was the 911 call to the first epinephrine. And the reason they picked that, as opposed to their secondary outcome, which was on-scene time to first epi, is the time from emergency call to first epi was the thing they measured in Paramedic 2. And if you recall, Paramedic 2, randomized control trial, epi versus no epi, and what they found is improved ROSC, improved survival to hospital discharge just a little bit, but among survivors there was increased neurologic devastation. And one of the big criticisms of that is it took them a median of 21 minutes.
Oh, it was 21. I was thinking it was 18, but I knew it was a long time.
Long time.
Yep. Long time. I did, by the way, take the ESO data set and said, well, what is it here? And in the U.S., at least among ESO customers, it is faster. It's more like 18 minutes. So it's not that much faster. So what they wanted to know is, do we get it in faster? And we're going to measure it. One is 911 call to first epi. Second is on-scene to first epi. All right, let's go through the results. Now, you actually had some questions. We're going to go over to table 1. Before we get into the results, although this actually is results, table 1, what was your observation about this?
Yeah, so there were a couple of things that I think are just worth looking at. And again, the study was not designed for this, and appropriately in table 1, they did not run a statistical test about this. I love it when people, they write a paper and they run a statistical test about the difference between male and female gender. That just is, right? That's not been studied. That's the way that it is. Yeah. And so they just present it that way. So that being said, we're not going to be able to say this is statistically significant in one way or another. It's just a gestalt. It's a the whiff test. Yep. When you look at that, the compression fraction, first of all, congratulations to Salt Lake City Fire Department.
Yes,
those are pretty impressive compression fractions, right? I mean, the lowest one they've got is 83.
My guess is they're doing continuous.
Yeah, I would think so. That's about the only way that you could do that, and which. We can go into the argument of that's physiology too, right? Because when I take a breath now, as far as I know, I don't have a cardiac pulse.
Right.
So the compression fraction is high in all of these. That being said, it is slightly lower in the IM group versus the IO and the IV group, which to me was kind of counterintuitive when you first thought about it. You would think that not futzing with the IV would allow a higher compression fraction. Again, I don't know that it's significant necessarily. It was just curious. It was curious. It just stood out to me a little bit.
So the interesting thing about compression fraction, we set as a metric in the Fort Worth system a really high compression fraction, and we were hitting it, and our survival was dropping. And lots of confounding variables here, right? Sure. But what we found is the way we were hitting above 90% is really easy. We just weren't checking for pulses. Not optimal. So sometimes a higher number isn't better. So if we want to say we see a difference in the baseline characteristics of a group, so for example, chest compression, we typically say when I see a difference, the main thing I want to know is it clinically relevant, even if that difference is real. So let's say it is statistically significant. Does that have an opportunity to bias the results? And if it does, which way would it bias them? So in this case, compression fraction has zero opportunity, I would think, to impact the results because the results here are not survival. It's just how long did it take you to give the epi. Now, maybe your point about distraction, maybe there is a way it could impact it. But if I were to say, looking at survival, which way would this bias it? It seems like it would bias it against IM. But as it turns out, it's just an interesting discussion because they're looking at response times and not response times, drug time.
Right.
And then you saw something else in here too, right?
Yeah, it's interesting. The advanced airway placement numbers are a little bit different. I mean, to me, they're basically the same in IM and IO at 88 to 92%. But in the IV group, it falls to 81%. And again, almost like compression fraction, we could debate if you're above 80%, is there really a clinical difference one way or another? Maybe, maybe not. Likewise, I honestly don't know the right answer about whether there should be an advanced airway and what type of advanced airway. And it doesn't, in the table at least talk about which type of advanced airway it is. But as as we saw here at this conference, the nation has kind of flipped in
the rise
world,
of the
right?
supraglottic.
The supraglottic is now the most common airway in cardiac arrest in the United States, which is an interesting thing to see. I think I could argue a back valve mask may be fine, but so it's just an interesting difference, and why. To me, it's more of a question of why would we have a difference in advanced airway in IV versus this time? Is there something else that was going on, in the system?
Is it personnel related, or is it was the right people able to do the things in the, who knows?
Let's get to the results.
What did we find?
So they looked at time to epinephrine in 3 groups, IM, IV, and IO. And what they found is IV and IO statistically were identical. And I mean, I say statistically, but 15.3 versus 15.3. I think that meets lots of definitions of identical.
Okay. All right, fair enough.
These are average numbers, average times. They do report standard deviation as they're supposed to. So 15.3 minutes in the IV or IO versus 12.2 minutes in IM, and that is faster. It's 3 minutes faster. That's the difference. There's a confidence interval, if you care, from 2 to 4 minutes. And if you really care, and you shouldn't, but if you really care, you look at a p-value, and it's really small. So statistically. Now, what about on scene to epi? Same results, also 3 minutes faster. So great, you can give IM epi faster. I'm not shocked by this. I think this is what we're expecting. It's also not the question we really want to know. It's step 1 of the questions we want to know. Yeah. What they have shown is that it's faster. Now the question is, does it improve survival? Yeah. Because that's what we care about. Well, it turns out that they have presented some results here at NAEMSP, and I'll go over those. Survival to hospital discharge. Now in this group, they combined they looked at IM compared to the combined group of IV and IO.
Which, given the similarities above,
makes sense.
Yeah.
Right? So what they found is improved survival. Odds ratio, this is adjusted for all the Utstein things. Survival to hospital discharge, 1.81. So an 81% improvement in the odds of survival to discharge. It is, I would say that's clinically significant. It's also statistically significant. The odds ratio, the confidence interval doesn't include 1. So that's great, survival to discharge. Once again, epi does something we don't care about. How about functional neurologic survival? And this is the big thing with epinephrine.
Yep.
This is improving functional survival. Now, to be clear, they're not comparing epi to no epi. They're comparing faster epi via IM to slower epi via IO, but they found improved survival. So overall, functional survivor, and these are all comers, not just shockables, 5.9% in the IVIO versus 9.4 in the IM. That is an adjusted odds ratio of 1.77, again, on one side of 1. So this is statistically significant. So it looks like it's faster, and it looks like it improves neurologically intact survival. Just to be clear about this, feasibility study, right? It is too early to tell. I think we need a randomized control trial. The authors are screaming we need a randomized control trial. I don't think that I am ready to change practice yet, although this is better evidence than when I changed to an epi infusion. I probably should mention that. But man, I think it's really compelling, and they are clearly setting themselves up to do the randomized control trial. So really exciting stuff.
Is it fair to say, because there might be some people watching and listening that, why would they do a feasibility study, number one? we're gonna get some information from it, but I mean, it's a feasibility study, right? So
Sure.
is it fair to say that this either helps them move on to that next step for a randomized control study, or gives another entity more evidence to propose that RCT and actually get that going? You know what I'm saying?
I do. I think that you asked two questions. I
Yeah.
think the answer is yes to both of them.
Yeah.
Whether they do the RCT, somebody else does the RCT, there to see a difference. We're talking about, was that 3% difference in survival? You need a lot of patients. So I think they would have to enroll a lot of patients, a whole lot faster with multiple agencies.
Yeah.
But yeah, I haven't talked to them. I don't know if they're planning on doing the RCT there. My guess is they are. The other thing it helps with the IRB. When you're doing an RCT.
Didn't do any harm.
Right. And there's certainly a suggestion of benefit. So, yeah, I think that is good stuff. Now, I'm sorry, Brent.
No, I was going to say that the other thing is I'm not sure it's only time. And I know this is just feasibility, but as we go think about that RCT,
You mean
the
that's
questions
having
that you want to
the
answer,
effect?
right? The fact that you are not having an epi spike initially in your cardiac arrest, right? You're having almost a depot epi that's kind of hopefully smoothing that out a little bit, may have a benefit separate and aside from the fact that it's a couple of minutes earlier. So it would be really interesting to know, is the total dose of epi change over time in an RCT? This is not big enough to do it, right? But just that notion of, are we actually changing not only the timing, but the phase of delivery, if you will?
So that is a really good question. And let me just say, I hope like hell what you suggested, the depot effect, is there the smoothing of the spikes of multiple boluses, because that's the rationale for why I switched to infusions. And again, this is better evidence than I had when I did that. So let's go over why I say the point flew over the head of Twitter. It seems like points and Twitter heads are missing each other a lot lately, or X or whatever the hell it is.
Yeah.
There was some discussion. Peter Antevi posted an advertisement, right? Peter is trying to get people to pay attention to the podcast. So you put something on Twitter to try to get people engaged.
It worked.
It did, which is the point. Strong work, Peter.
Yep.
I try to do that to get people to listen to my podcast.
Yeah.
Never works for me, but it works for Peter. And boy, he said, does, giving IM Epi versus...
Yeah, what if I
IV?
told you?
Yeah, would you believe it? Stay tuned. Perfectly appropriate. I get that. So there was discussion, well, why the hell would you even do this? This is unethical. Why don't you you got the IV right there, why don't you just give it? But do you have the IV right there? And can you have the IV right there? This is one of these things that we think every EMS system in the world is exactly like ours. I'm a paramedic. I can start I, of course, never miss an intubation or an IV.
Of course.
It's in immediately. And I can give it just as fast via IV. Number one, I think you're full of shit. I think you're lying. Number two, even if you can, and you probably do get most of the IVs in on the first attempt, you're a paramedic and not every system has paramedics. If you think there are entire states out there where 90% of their systems are BLS, and there are other lesser states than, say, the great state of Texas, which is, I don't know if you know this, a delegated practice state.
Yeah, I've heard that once or twice.
Where scope is whatever I say it is. In a lot of states, EMTs cannot give epinephrine. So, or I'm sorry, they can't start an IV.
Arrest.
Yeah, they can't start an IV.
That's right.
So if this turns out to be able to get epi in sooner, and that has an advantage, giddy up. This is a systems issue.
Yeah.
Now, it is very interesting here. I'm glad that I had that little stumble about, you said in cardiac arrest. Brent, you do not work in a full-on yeehaw, wild, wild west delegated practice state. And EMTs, from what I understand, in North Carolina, cannot give IM Epi in cardiac arrest. During the plague, You said you had an approach that might be able to let them do it.
We didn't actually do it, but we joked about it, right? We joked about saying that.
Well, the joke's even better than doing it.
That every cardiac arrest was presumed to be anaphylaxis, so that we could at least start with some IM Epi.
Because that is in the...
That is in scope.
Yeah.
And as a matter of fact, because of the shortage of auto-injectors, EMTs can actually draw up Epi and give it IM in the state of North Carolina. So if this comes to fruition, it's just a dosing question, right? At that point,
I like it.
So I think it really opens up that opportunity. Yeah.
So I dig my heels in as a absolutist about delegated practice, and my colleagues who do not work in those types of states just say it's not that bad. You just need a little creativity. And apparently this is the creativity you were talking about. I like it. So what was the dose? You mentioned the dose. There's a difference. They did 5 milligrams IM Epi versus 1 milligram IV. Isn't that high dose Epi? Haven't we already proved that that's wrong?
Well,
and doesn't work.
But because it's IM, right? This is an equivalency question, right? So once absorbed, this is the best equivalency to 1 milligram. So I don't think this is a high dose Epi question. I think this is just if you only gave 1 milligram IM, to your point, we would be underdosing that.
Right.
Did it say, I'm going backwards a little bit, did they say if they gave it in the thigh or the deltoid or?
My guess would be they told them just to get it in, but let me take a look.
Yeah, I was just curious because, because we didn't really talk about it, but this idea of the low flow state or no flow, right? And if somebody's truly in anaphylactic shock, they're sort of in a similar, maybe not quite as profound, but.
That was one of the discussion points I heard. I think it's a very valid point on Twitter. Lateral thigh.
Oh, lateral thigh.
Yeah,
okay, perfect. Yeah.
Nice eyes, Brent. Yeah. So the question was, the question completely escapes me. What the hell were we talking about?
While the question completely escapes you, we do want to cover one thing, which is in the table, it said they all received 3 milligrams of epinephrine. Well, if they got 5 milligrams IV or IM to start, how is that?
Yeah. It was the number of doses.
Total number of doses.
Right.
Got it. Okay. So it's 3 doses
Correct.
of Epi each.
Correct.
Okay. Got it. That makes sense. So while you're thinking about that question, I want to just posit one other thing that may be beneficial here. From my perspective, one of the most important things about a cardiac arrest is the choreography of it. And, I have, again, somewhat tongue-in-cheek, not as much tongue-in-cheek maybe as it should be, but, the evidence, if we're truly practicing evidence-based medicine, not all the confounders would be controlled, of course, but if somebody has a cardiac arrest in the hospital, we should call EMS, roll them outside, have them resuscitated, and then bring them back inside.
100% agree. Yep.
And it's not because of a knowledge piece per se. I think it's because the routineness with which EMS does this, they get the choreography right.
Yeah, it's a CRM.
And we're not taking people to the hospital intra-arrest anymore. So the number of times cardiac arrest or practice
it's even less now.
Yeah. Right? And so I don't say that to be pejorative against any colleagues. I just say that to say the choreography really, really matters.
This really is an area I love my colleagues and I respect that they have a specialty that I don't. Resuscitation is an EMS specialty. This is what we do because we're the ones who do it. And I agree with you completely. I think every in-hospital resuscitation, even the ones I'm leading, if I'm going to be honest about it, are clusters compared to what EMS does.
Compared to the way EMS does it. And what this does is it takes one more of those early resuscitation distractions and moves it off the table, right? Because I've got more providers that can do it. It's a one-time. I know everybody gets IV on the first time, but it still takes a second. It still is another, and so we can go back and focus very early on the right thing, which I think that choreography we were talking before, we started about, I think that's one of the benefits of hypothermia too. It's not the treatment itself, it's that it's a protocolized approach for the first 72 hours of care, and it prevents things from getting in the way. Yeah. And this is one of the things that we can just hopefully maybe get off the list if this proves true in an RCT.
Right. It's interesting when I was reminded all of a sudden of the ITD when you were talking about therapeutic hypothermia, that your point is it's not necessarily the therapeutic hypothermia because we have some impressive data now that says just prevent fever and you'll be fine. It's more the protocolized approach, the paying attention to things, and there's this other benefit that's driving the improvement. The thing that, did y'all use ITD? And
we did.
And I know I heard Paul Hinchy say this, the main benefit of the device
is the timing line.
Yes.
right? To prevent, because we know for sure that hyperventilation is really bad. And oh my God, did we see that today here? That's a different talk. But I mean, one of the research presentations this morning around TBI, I mean, hyperventilation is just horrible. Yeah. And so the notion that we could in some way help that one piece be choreographed appropriately. Right. Hinchy said this, but I'll steal it from him. He said, well, you should just tape the ITD across the chest and look at the timing light. And that may be, confirm the same benefit.
There's a Elegard joke in here somewhere, but I'm going to let it pass. I love it. So the last thing that I want to say, because Dr. Myers, I know you have to run, when we were talking about the dose, so the other thing, 5 milligrams IM Epi versus 1 milligram IV, remember the concentrations are different. We're talking about 1 to 10 versus 1 to 1. All right, so I think the bottom line take home, I'm not ready to change my practice. I wouldn't recommend anyone else do it, but boy, I want this RCT, and it definitely, if the RCT confirms this, I will absolutely change my practice.
It would be one of the biggest game changers we've seen in quite a while.
Short of, because this one's easy as opposed to the other thing we know improves survival, which is really hard work. Speaking of Paul, the paper he did, I think it was his fellowship paper about PICC or CPR. Right. Great work. Shows this is hard, and when you do it right, it works. Yep. Well, guys, that's the paper from NAEMSP in Austin, Texas. Y'all take care, and we'll see you next episode.
See ya.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.